Hello and welcome to the pre-hospital ketamine talk. This talk was initially prepared by Ashley Bellinger over at Leicester EMS. It was adapted for the Holliston Fire Department by Assistant Chief Brian Kelly and narrated by myself, Jamie Eastman, one of the EMS coordinators and paramedics in the department. Thank you and welcome. Learning objectives for the pre-hospital ketamine talk today include, at the end of the session, we'll be able to discuss indications, contraindications, the doses, route of onset, duration of effects for therapeutic uses of ketamine. We'll describe the requirements as a paramedic to fulfill an order and to follow those appropriately in Massachusetts. We'll describe how we're going to communicate and document our usage of ketamine and what it was regulated and how it was given for the patient. And finally, we'll discuss and determine best practices for how to administer, when to administer, and then how to do your post-ketamine assessments and management. More specifically, our agenda today will include introduction. We'll talk about pharmacology, considerations, indications for use, our Massachusetts Office of EMS specific protocol, and our Holliston Fire Department standard operating procedure for ketamine. We'll go into our dose and our routes, our post-administration monitoring, and our communication documentation, specifically requirements by the state of Massachusetts, and our regulations and policies internally here at Holliston Fire Department. Introduction to ketamine. For years, ketamine's been used in the hospital. It's been used in veterinary clinics for animal patients as well. And you're going to see it adapted now here in the pre-hospital environment in Massachusetts for three major categories. One being pain control. Ketamine has both pain and sedation properties, which make it a great medication when used and employed appropriately. We'll talk about that throughout this whole talk to take care of pain and sedation. So pain control is one when it can't be reached by a drug with lesser pain properties. A lot of times fentanyl isn't enough on patients that have a high pain increase or high pain tolerance. It can be used for chemical restraint. We can use this if a patient is having excited delirium and needs to be calmed quickly with an intramuscular medication for their safety and the safety of the crews around them. And lastly, as we talked about, with sedation. So it has both pain and sedation properties and can be used appropriately in EMS for a lot of things listed here. Outside of pain control, chemical restraint, and sedation, however, you must have specific medical control direction here in Massachusetts. And for the Holliston Fire Department, that is going to be with the Milford Emergency Room physician. On call will be our medical control, and we'll contact them through Worcester CMED on a recorded line, either by phone or by radio. It's important to always tell you a little bit of history of the medications and their availability. So firstly, ketamine was developed in 1962 by Calvin Stevens, who's a PhD pharmacologist and medical scientist. And what he was doing was basically taking PCP, or more specifically known as NMDA, and adapting it to use as a clinical practice for patients to be used. He found that that medication caused what we call dissociation, which means it has multiple properties and can affect multiple receptors in the brain in order to give us the desired effect. That's where we talk about pain and sedation control. It hits multiple receptors, and it's very helpful for a lot of things in kind of a one-stop shop for medication in specific patient populations that we'll talk about continuously through this talk. So as we mentioned, there's a lot of usages for ketamine, and it has a wide net that can be cast in multiple locations. Like we said, in the battlefield, we can give it in the OR, we can have it for veterinary patients, but the pre-hospital environment, we have it very specifically, as you know, and it's a very controlled medication because it has such a wide usage. Office of EMS for Massachusetts specifically describes ketamine should only be administered to patients in the following situations: behavioral emergencies, adult; pain management, adult; sedation for intubation patients, which will not be utilized here in Massachusetts in the Holliston Fire Department yet until we have RSI; and then for patients with sedation and analgesia for electrical shock therapy in adults in cardiac. And any other usage outside of those will require explicit permission from all-ML control, which we said earlier for the Holliston Fire Department will be the Milford Hospital emergency physician on call, and will contact them through Worcester CMed on a recorded line via telephone or by radio. Very important, must be recorded conversation through CMed with the Milford Emergency Department physician for Holliston Fire Department. Here's some YouTube videos talking deeper into ketamine. This slide here and the next slide will attach these videos for usage directly into the app as well, so you can watch it separately if you need to after this as part of your project in following the ketamine lecture. So the actual pharmacology of ketamine. So first off, the drug class, it has three distinct usages. It's analgesic for pain medication, it's a sedative for sedation, and it's a dissociative anesthetic. So it really is anesthesia when you get down to the brass tacks of it, because it's giving you both pain and sedation usages. So those three things are its actual drug classes. Its description is that it's a rapid acting. So depending on the route, this is a little bit faster or slower, but it has a pretty good rapid onset to be able to give you the desired effect, and it's dose dependent. So the higher the dose, the faster the reaction is going to have, and the higher the effect it's going to have with it. So that's why you'll see very specific dose dependent dosage depending on the type of result you're trying to get out of it, whether it's pain management, sedation, or dissociation. Mechanism of action we talked about, very similar to PCP, and that physician, the PhD scientist that discovered it and was using it in the OR wanted that effect. He wanted to have that effect on the NMDA receptors, so that patients may actually remain awake. Their eyes will be open, but they'll be disassociated with reality a little bit, so they can have a lesser effect and not as deep as effect. May be able to answer commands, maybe not, depending on the situation, depending on how much they've had. Pharmacokinetics, so their onset's about 30 seconds for IV. Pretty rapid acting. That's the desired effect you want, especially in some patients that really need a quick acting. And then again, intramuscular, 3 to 4 minutes, which again for IM is pretty fast. The duration is about 10 minutes for IV and 12 to 25 IM. That's why you'll see some of those redosing times. But you can have dissociated states up to 20 minutes or even longer, depending on how much is going on. We'll talk about as well if the patient has medications on board already, if they've been polypharmacy, if they've taken recreational drugs, those times are going to extend as well. So be very precautious to be looking for that in your patients and your follow-up assessments. Continuing with pharmacology, the half-life of this medication is about 3 hours. So again, depending on the dose is how long it's going to stay in the system. And certainly if we give additional dosages with medical control or depending on what the policy protocol says for Massachusetts, you could see a long effect on this. And certainly if the patient has other medications on board, that's going to extend even further in the ability to clear those. Other things that affect the half-life in this could be kidney function. So if you have a patient that has poor kidney function, it could be even longer so for them to be able to process and excrete this out. Contraindications. Very important to understand a known hypersensitivity. That's going to be hard to tease out in a lot of these patients unless they're very well up to date with what's going on, but be thinking about that when you're doing your rapid assessment prior to administering this medication. The big thing about ketamine too is we say that it makes your blood pressure go up. Kind of, not kind of. That's going to be because the ketamine is going to recept your beta responses. So what you'd see if you give a medication like albuterol, where you have an increase in heart rate, increase in blood pressure, very similar here. If you have the catecholamine storage already in your body and you give ketamine, it's going to help you release that a little bit so that it will do that. So we want to think about patients that are having high blood pressure and maybe avoiding this medication to create an even higher blood pressure for them. Specifically, if we were working about pain management, we could be thinking about maybe giving some fentanyl first, see how they do. If that lowers the blood pressure some, and we can give ketamine as a secondary pain medication if the fentanyl did not work. We do want to note, though, that head trauma is not a contraindication for ketamine anymore. It used to be because of this. We were worried we were going to cause hypertension and cause further head trauma to the patient, secondarily head injury. Not necessarily the case anymore. We just want to be cautious and be considerate when we're giving this medication that we do not increase blood pressure too much. Precautions, emergence reactions. So as the ketamine wears off, people can have a bad, literally trip on this medication. So if we're seeing them having hallucinations, delirium, confusion, or excitement, irrational behavior as they're coming out of this ketamine medication dose, a lot of times we have a longer trip. For Holliston, for example, if we give ketamine in Holliston, we take a patient by ground to UMass or Boston, along our route, 15, 20 minutes down the road, as the ketamine starts to wear off, the patient could be having some hallucinations or delirium. We want to be Johnny on the spot and be thinking and looking for this and be prepared to give something like a midazolam or a Versed, right, to help. The benzodiazepine will help calm them and sedate them through this emergence reaction. It happens quite a bit. Really happens in kids the most I've seen personally, but it's certainly possible with adults too. You'll see them come out irrational and kind of having like a bad trip almost on this, and we'll need a little bit of medication, benzodiazepine, help calm them through that. I'd avoid giving additional ketamine if you have emergence reaction because it's going to make the problem worse later down the road. You really need to get medical control on the phone and talk about giving a little bit of Versed. That'll be discussed with the physician, likely to be the normal sedation dose for midazolam or a half a dose as part of this. Certainly for side effects, hypertension, we talked about tachycardia, hyperthermia, all those things you're going to see with a beta drug process. You can have some laryngospasm, so be thinking about having your airway products out. I would have a BVM out nearby if you're giving ketamine. Assign your BLS partner to have the BVM pulled out of the bag ready to go in case you need it. Nystagmus, you'll definitely have some eye changes. You'll see pupil dilation or even constriction. You have nystagmus 100% with this patient. You'll see that, especially as they're coming off the drug, you'll see that change. Change in their tone, nausea, vomiting, dysphoria, disorientation, flashbacks. Again, those emergency reactions will trigger a lot of these. It could have hallucinations, psychosis, so again, be thinking about that. And if you're giving a large dose, or if you're giving a dose of ketamine after someone who's already had a lot of medications in polypharmacy, be thinking about respiratory depression. Again, having that BVM out, thinking about an end-tidal CO2 nasal cannula to help you track the respiratory rate and your CO2 exhaled are all important here, being part of your heavily on your assessment given this medication. And lastly, interactions. We talked about a few times, or I'll say it again. If the patient has a long alcohol use or has been using narcotics, consistently or large doses of those in the day that you're giving the medication. Be thinking about that, and then you want to be thinking about just monitoring them very specifically for this through that process. Pre-hospital considerations for ketamine. For Massachusetts, is for adults only, so age of 18 or above is the only usage here. We want to be thinking about that for behavioral emergencies, that this is on the paramedic, not on the law enforcement. So if a cop's yelling at you and you arrive on scene that you need to give sedation, really do your assessment first. Even if we're talking about having 3 or 4 cops trying to hold someone down, that place is chaotic, you want to make sure that patient is in their right mind, and if they're not, assessing what's going on. Is this drug induced because we can have interactions with other medications the patient's taken so far? If the patient's actually hypoxic because the cops are pushing on their chest or making so they can't breathe. We'll talk about some anecdotes and when ketamine has been used erroneously and led to complications further on with this. Be thinking we have very specific protocols in Massachusetts, and then again policies here at the Holliston Fire Department about giving medications for behavioral emergencies and making sure we're well read on those and that we're doing a solid assessment for administering this medication, working in conjunction with law enforcement, not necessarily against them, but remembering that if we're pushing the medication, it's on the paramedic giving the drug, not on the police officer who's yelling at you or maybe screaming at you that you need to give medication for this patient. Again, our contraindications for this, we want to be thinking about patients that have a known hypersensitivity. Again, hard to tease out. Be thinking, doing a solid sample assessment as we can with the patient or with people around them, surrounding bystanders. Patients that are pregnant, we want to avoid ketamine because, again, the blood pressure changes are not good and it can affect the baby, the fetus, excuse me. And then be thinking as well, if we're having a high blood pressure, very hypertensive crisis, or we're very tachycardic, it's going to put the patient at further risk for higher blood pressure, higher heart rate. We want to consider another medication. An example would be if we're thinking that this is pain related, we would give something like fentanyl or morphine to be administered first and see how the patient does with that. If we can lower the blood pressure, try and reduce some of the pain, and a patient's still having significant pain, we can use ketamine as a second medication. If this is more of a sedation thing, we could start with a benzodiazepine like midazolam or Versed first and see how they do with that. And then again, with medical control in conjunction, we can talk about using ketamine as a second dose. Okay, so when can I give ketamine here in Massachusetts? So very specifically, the protocols for OEMS are as follows. Pain control. Under the severe pain protocol in protocol 2.13 is our indication here and how we'll be able to give that for pain management. For sedation of the intubated patient, so again, to clarify, not for patients that you're going to intubate yourself, RSI-wise, medication-assisted intubation, but for patients that have been intubated, for example, during cardiac arrest, who regain consciousness to get ROSC, we can use ketamine to help keep them sedated after intubation. In cardioversion, so if the patient needs to be cardioverted or paced is warranted in protocol 7.6, we can give ketamine as part of sedation analgesia for them. And lastly, behavioral emergencies, patients who are displaying violent behavior and endangers the patient as themselves, others around them, or EMS and providers. Patients who are violent for other conditions like delirium, which is also a risk to the patient and the providers around them, can be found in protocol 2.4. Okay, dosing and route of ketamine as per the OEMS protocols listed previously. For behavioral emergencies, be thinking intramuscular only. We say this because it's safer. You're not going to probably be able to get an IV on this patient if we're thinking they're so behaviorally unsound that we need to give them ketamine. We probably cannot give them an IV safely in that process, so it's going to be intramuscular. This is going to be your highest dose of ketamine administered at 4 milligrams per kilogram IM only, as we said, with a max dose of 400. So we're thinking 100 kilogram patient, the most you'll be able to give them is 400 milligrams IM only in a single dose. If that patient is over 70 years old, we're saying that we think they have some cardiac problems. That's natural for someone over 70 years old. We want to reduce that dose. So the max dose for an older patient over 70 years old, male or female, is going to be 2 milligrams per kilogram IM only for a max dose of 200 milligrams. Okay, so be thinking that half dose is because of the cardiac effects of the hypertension and tachycardia associated with giving ketamine. We don't want to cause them to have a heart problem or have any cardiac ischemia from our ketamine administration. For pain, we have options, IV, IO, IM, or intranasal. So for the IV, IO, it's going to be a very slow push. Again, the faster you push the dose and the higher the dose, the more likely you're going to have interactions with the medication. So keep that in mind. So 0.15 milligrams per kilogram, IV, IO, slow push, may be repeated once after 15 minutes. If you're going to give it intramuscularly or intranasally, it's going to be 0.3 milligrams per kilogram and may be repeated intramuscularly or intranasally one time after 20 minutes. For patients getting cardioversion or pacing, we can administer IV, IO, or IM. If it's going to be IV, IO, it's going to be a slow push of 0.1 to 0.5 milligrams per kilogram. If we're going to consider intramuscular, it's going to be 1 milligram per kilogram, which may be repeated after 5 minutes. If the patient's having continued pain at that 5-minute mark, remember our half-life for this our onset 3 to 4 minutes for intramuscular. So if no result by then, we could certainly give another dose for them to be more comfortable through the cardioversion timing or the pacing. For sedation of the intubated patient, again, I want to stress this is not to medically sedate a patient for intubation, for you to intubate the patient, but if you intubated the patient during cardiac arrest, or if they were unconscious and you were able to intubate without medications, now they've regained consciousness and they're pulling out the ED tube or uncomfortable with intubation, we can give ketamine as a sedative and analgesic for the patient that was intubated previously. That's going to be 1 to 2 milligrams per kilogram slow IV IO up to a max of 100. May administer another half dose 5 to 10 minutes after that twice. So maximum total dosing would be 200 milligrams IV IO in the pre-hospital environment. If you need additional dosages for a longer transport, for example, if you're transporting the patient to Boston or UMass or a longer trip, certainly use the early medical control with Milford through the Worcester CMed record line via telephone or radio to ask for more dosages or repeat dosages. Now talking administration procedurally. So firstly, we really want to stress to do a solid assessment. It can be very easy to walk into a patient that the police are trying to control or organize and using physical restraint, trying to make them safe. And we think that the team thinks that a chemical restraint might be warranted. I stress, please do a solid assessment. Get a blood pressure if you can. At least get a pulse ox. We know the heart rate. Give a manual pulse on the patient's radial. Assess their ability to breathe on their own before we cause the issue. We'll talk about, again, anecdotes shortly about when ketamine was given at the wrong time and resulted in injury and death to patients. So a solid physical exam, the best you can, even if you have to work around the police to get there, is very helpful for your assessment of the patient. Consider the risk and the benefit. Again, be thinking that you have multiple tools. Ketamine is a one-stop tool for a lot of things, but sometimes it's not the right tool in your tool belt. Starting with a fentanyl or starting with a midazolam and getting medical control to give ketamine secondarily or following the protocol so you can give both of them may be the better option. Be thinking about that. Be having a conscious decision on when to give this medication. Again, it's really well received, but again, sometimes it's not the right tool in the tool belt. Have that discussion with your partner. Maybe you have a solid BLS partner or an ALS partner you can work with to help discuss this, or consider medical control. Or, like I said, start with a different medication first, like a fentanyl or a Versed prior, and then work up to ketamine as a second dose. Remember, undiluted ketamine is only going to be given intramuscularly. Otherwise, we need to make the concentration 1-to-1. We'll talk about that shortly. At no time will you be giving this undiluted ketamine in the IV. Again, we'll talk about this shortly, what that looks like. Very important to label everything. When you're drawing up the medication to a syringe, you need to label it. I definitely have an orange medication label on there. Carry a Sharpie in your pocket, or we can get a Sharpie into the medication box. And certainly when you're diluting, you're going to be using an IV bag, so you really need to be certain that you're going to label the IV bag with the ketamine. You're going to have to waste medication if you don't use it all. It can certainly become a risk if you place it into an IV bag and hang that thinking that it's just normal saline when it's actually ketamine. Very important to label everything. I can't stress that enough. Even if you're the only ALS person in the ambulance, you're never going to be too sure what your BLS partner might do, or if you accidentally throw it away or something, it's going to be part of your waste. Again, documentation, I can't stress enough, you must label everything. All right, so here's some options on how we're going to give ketamine. So intravenously, we could do an infusion of ketamine, where we're going to put the medication from the vial into the bag and deliver that. Now, that's going to be a delayed option for the Holliston Fire Department. We do not have IV pumps yet. Once the IV pumps are become available and we have the protocol and procedures to do that, we can place this into option. But understand this is a way to start out. So again, we want to make the concentration of 1 milligram and 1 ml. So we're going to take the vial of medication. If it's 50 milligrams of ketamine, we want to put that into a 50 ml bag to make the concentration 1-to-1. If it's a 100 milligram vial, we can put that into a 100 ml bag of normal saline to make the concentration 1-to-1. If our vial is outside of those, we can just draw up the 50 milligrams and put it to a 50 ml bag, or just draw up the 100 milligrams, put it in a 100 ml bag, and remember that the rest is stored appropriately and has to be wasted at the hospital. Then you definitely want to label that medication as the sticker here in the bottom right-hand corner. They're orange to match the orange medication box at the Holliston Fire Department. And then we want to make sure, in this case, they'll be using an IV pump to give the medication, and then we can give it, I need to give a solid ketamine administration assessment. Now, if we're trying to give the medication specifically a dose, concentrated like this 1-to-1 in this infusion over time. For example, if we put the ketamine into a 50 ml bag and hang it with a 60 cc drop set, and it's just over time, we're going to deliver that medication over about 10 minutes. Okay, so that would be a slow IV push. That is an option that you can do without using an IV pump, and this is just going to be technically a bolus. But we're going to do it again over time. That's an option for you. But the actual infusion, for example, if we were to do ketamine 1 milligram per kilogram per hour, you would need an IV pump. This is probably the best way we're going to give ketamine at the Holliston Fire Department when we're using intravenous. This is the IV bolus. So again, we're going to drop our medication from our vial and we're going to place it into an IV fluid bag into a 1-to-1 concentration, 1 milligram and 1 ml. So again, if we have a 50 ml normal saline bag, we'll drop 50 milligrams from the vial, place it in the bag. We're going to label the bag at that point with the concentration ketamine, 1 milligram and 1 ml, and the total amount we put into that bag, okay? And then we're going to draw that back up into our syringe to make it 1-to-1 concentration for the dose we want to give the patient, and then we can push that slowly into the IV. If we're going to draw it up and not quite give it yet, we need to label both the IV bag and the syringe. Both need to have a label on them showing ketamine 1 milligram per 1 ml. Remember, after the administration, we're going to do our post-ketamine assessment and document that appropriately. Intramuscularly is probably the least involved processing in trying to drop the medication. Because we can give it undiluted, it's just pulling it out of the syringe to the directed dose we want to use, out of the vial, into the syringe, and then delivering intramuscularly. Same processes apply, a little aseptic technique, a little alcohol wipe of the skin, pinch the muscle, and place the ketamine in. hold a little bit of gauze over a Band-Aid for any bleeding that may happen with this, and then do your post-ketamine administration assessment and document your administration and your assessment findings. It's very important to conduct a post-ketamine administration assessment. A repeat detailed physical exam is going to be very crucial for your patient findings, for your success in giving ketamine, and for your appropriate documentation. We really want to be talking about mental status, okay? And you're going to see that change. Firstly, when they first give ketamine, the patients are going to come to this disoriented state. It could be, or a dissociated state. It could be eyes open and looking off into space. A lot of times they'll hold their hands over their head, like they're going to do like a very slow jumping jack almost. And the hands go over their head and they kind of fall back as if they're having this hallucination of falling back into the bed. That eventually will kind of slow them down and the medication will take its place. However, as that wears off, the patient could have an emergence reaction, and again, that's where we discuss getting on medical control and asking for a benzodiazepine such as midazolam or Versed to help them through that process. Having a keen assessment on mental status and a following additional assessments is important through this process. Airway. Okay. Be thinking that in larger dosages specifically, or if it reacts with other medications, we can have hypersalivation. You need to have suction out and nearby in order to be safe with this, because they may have enough hypersalivation and secretions that you may have to consider how doing airway intervention for them, such as a nasopharyngeal airway, an OPA, BVM, or even consider intubation if you have to, if that's significant enough. Be thinking if there's any associated nausea and vomiting, that you could give them a little bit of Zofran as well. The 4 milligrams IV dose is required if that's part of this process as well. Certainly, as they're coming out of the ketamine dose on longer transports, you may see this. Have some Zofran ready to go for the patient as well. As part of this post-ketamine assessment, you need to make sure you're doing a solid exam and using all of your tools to do that. Every patient you give ketamine to should have all of these things as well. Vital signs every 5 minutes. Absolutely. Place them on the cardiac monitor, get your 4 lead, set the blood pressure and vital signs to Q5 minutes. Get a blood sugar, 100% mental status change. We want to have a blood sugar to make sure we weren't missing anything, especially if we're talking about excited delirium type patients or behavior type patients. We could have missed the blood sugar. Certainly, if they were having any of those as well, we could be thinking that they were burning through their blood glucose store, so we want to know what a solid blood sugar is. Or if they're hyperglycemic the other way, we want to think about them and their ability to process glucose. I would 100% put this patient on waveform capnography. We need to think about the end-tidal CO2 nasal cannula. Certainly, if they're intubated and we're using this as part of the intubation process, we want to make sure they're on continuous end-tidal CO2. If you did IM before, because this was a behavior patient, and now they're finally calmed down, it's a great time to get an IV because, again, with the emergence reaction, you're going to want to have a nice access to give a benzodiazepine. Certainly, there could be additional dosages, so if the patient gets ketamine, they need to have an IV. It's fine to give them IM first. Once they're calmed down and they're relaxed, get that IV. 100% needs to happen as well. And then again, as we talked about, this does have cardiac effects. It's going to cause tachycardia and hypertension. It's very wise to also get a 12 lead once the patient's calmed down or their pain is calmed down, so we can know what our baseline or post-ketamine 12 lead looks like. On older patients we talked about, patients over 70 years old, we want to make sure we get the EKG after ketamine because there could be changes. We could certainly cause some cardiac ischemia from ketamine administration, given the hypertension and tachycardia as a possible side effect. So having a solid 12 lead required is also very important, especially on patients that have a known cardiac history or cardiac susceptibility. If you're giving a ketamine because of behavior, and we're talking about patients that are in a physical restraint, and you're trying to do your assessment, this is a phenomenal time if you're going to give the ketamine that maybe you need to loosen the restraint to do the exam. Once the ketamine has caught on, to do your physical exam, have the police officer maybe help you release the handcuffs temporarily or release the physical restraint temporarily so you can do a solid assessment to be able to get a distal CSMTs, to be able to get a radial pulse or a pedal pulse, to be able to access their chest for auscultation, to be able to feel pulses and do a good respiratory assessment. If for some reason that cannot happen, you shall document specifically why, what the safety risk was, what the rationale was, and remember that you gave the ketamine, it's on you, so the police officer involved helping you really needs to help you. If that's not the case, we need to have specific documentation in the narrative why that could not happen. Okay, so now some anecdotes about when ketamine maybe wasn't the best option, but these are things not to scare you, but to understand the significance of what can happen with ketamine if not done properly. So this patient here was stopped by police. He was given specific tactical maneuvers to take him to the ground. They were using specific holds to try and gain control of him as he was kind of fighting back, it sounds like. The paramedics that responded as well, thinking a behavioral situation, gave a large dose of ketamine to this patient. And he eventually, when he was in the ambulance, was not breathing and didn't have a pulse, was in cardiac arrest, ended up with brain damage and later died. Charges were filed against the police officers and eventually the paramedics. And each of them were criminally charged with manslaughter and negligent homicide. So again, be thinking, working in conjunction with police, doing a solid exam, and then your post-ketamine assessment. So if there is breathing problems or we have a change of mental status or change of pulse status, change of respiratory status, we can affect those things appropriately. As soon as the ketamine goes in, that pulse ox until the CO2 goes on, no questions. You've got to be able to do those. Definitely do an exam beforehand. I would highly recommend, getting a pulse ox on the patient before ketamine. I know it's hard to do when there's 3 or 4 cops holding the patient down, yelling at you, screaming at you, barking orders. But when tensions are high, you've got to be slow. You've got to be that quarterback, see the whole field before you pull trigger on the ketamine for these patients. And again, thinking maybe something else, such as a benzodiazepine or a fentanyl beforehand could be a different option and a safer option for you in this particular situation. Another case, this gentleman was in a prison, was in a fight, and was being held down by multiple prison guards. Again, face down, can't breathe, lack of oxygen, instead of now he's hypoxic in this fighting situation. So instead of giving oxygen, they gave ketamine to try and gain control. The medical examiner later found this to be a homicide due to hypoxia and brain damage and a regular heartbeat because of this. So they didn't get a solid physical exam. They didn't see that his heart rate was fast. They didn't see his respiratory rate, and his pulse ox was low. They gave ketamine, making those things worse, and eventually led to the patient's death. So, not to scare you, but again, understand these are the outcomes of what can happen if you don't do a physical exam ahead of time, and if you don't do a post-ketamine exam afterwards. So again, getting the 6 or 10, 15 officers off the patient, allowing the patient to be supinated, giving them oxygen, end-tidal CO2, pulse ox, full vital signs, full physical exam, as are all part of this process, okay? And don't get caught up in, oh, he was a prisoner, oh, he's a known drug addict. That's not a good answer when talking about patients' lives. You need to make sure you have a solid physical exam, a solid, detailed follow-up physical exam after medications, and continuously along your transport. Documentation. So on policy 512, the Holliston Fire Department is talking about our ketamine policy. When you're giving ketamine for pain control, you shall include in your PCR report at minimum the indications of what ketamine was, the patient's weight, the dose that you're desired to give, the method of administration that you're going to give the patient, and your post-ketamine administration assessment. Those are all required documentation things that you must include in your PCR as part of giving ketamine for the patients with pain control. Again, policy 512, ketamine usage at the Holliston Fire Department. Your PCR shall include at minimum for sedation, your indication for administration of ketamine, the patient's weight, the desired dose, the method that you're going to administer it, what the providers observed desired, undesired, any sort of side effects with ketamine. So if it caused any complications or if it did the right thing, you should explain that. And then a detailed post-ketamine administration assessment. What you found with all those vital signs required as well are all important and required in the Holliston Fire Department policy for documentation of ketamine and sedation. Probably the most important policy, 512, ketamine usage for behavioral emergencies. You must document, and then document some more. Okay, so for the Holliston Fire Department policy 512 ketamine, paramedics shall in their PCR include the minimum for behavioral emergencies, a detailed assessment with clear articulation as to the signs and symptoms present that led the paramedic to conclusion that ketamine administration was necessary and appropriate. We're talking about taking away a patient's ability to react and have good judgment. Okay, extremely importantly, document this. You must document the attempts to de-escalate the patient verbally prior to medication usages. Okay, so again, in accordance with the state protocol, behavior emergencies, adult, pediatric, and behavior emergencies, restraint, adult, pediatric, specifically the things you've done to de-escalate them verbally prior to medication usages. And remember, though the procedure or the policy for OEMS or Holliston Fire Department does mention pediatrics, it is not indicated for pediatrics in ketamine, only for adults ages 18 and older. If physical restraints were applied, what type they were, how they were applied and who applied them, and then their follow-up assessment with those. So making sure you have circulation, sensation, movement of distal extremities after the application of physical restraints. EMS providers must consider the risk versus benefit of ketamine administration for the behavioral patient. Again, explaining why a different medication may not have been the best choice, why ketamine was the best choice, is important to document and understand, and the risk that was discovered during that time. Documenting all desired, undesired, and adverse effects of ketamine. So if it worked, explain it. If it caused an undesired effect or an adverse effect, you need to explain that in detail and interventions you did to help the patient with those, such as emergency reactions, hallucinations, all those things. Hypersalivation, suction, respiratory distress or arrest, PVM, OPA, NPA, all those things. And lastly, a detailed post-ketamine administration assessment in these patients is crucial. I can't stress it enough. With that, I thank you for your time. I think it's good to understand that ketamine is a wide variety of usages. This drug, just like any drug, is neither good nor bad, okay? It has options for you, but it's an option. It's not the only drug. It's not the best drug. It's not the worst drug, okay? But know that it's a good tool for your tool belt. Can be used in conjunction for a lot of things, as we mentioned. If you have a solid understanding of the pharmacology and you have a thoughtful usages in the patient selection you're going to use them on, knowing what to look for, knowing how that can be employed is very important. Much like a good carpenter, you don't only have one tool. You have a full tool belt to use here. Understanding that though ketamine, it may be an easy option for you, it might not be the best option. So be considering like a fentanyl as well, or in use of prior to midazolam as well, or whatever. Understanding that a lot of those do require you to contact medical control. Again, I'll say it for a 10th time, medical control for the Holliston Fire Department is through the Milford Emergency Department physician on a recorded line through the Worcester CMed radio or telephone. With that, I leave you with this. Thank you for your time. Please reach out to any of us with questions, comments, or concerns, and we look forward to a successful usages of ketamine in the Holliston Fire Department and our surrounding communities in accordance with policy, procedure, and OMS protocol. Thank you. Have a good day.